travels up the cranial nerves, right? What do we do in response to that elevated pressure? We get a parasympathetic response that comes back down and slows down the heart. So this is what's happening in us all day long, is our pressure changes. We keep it in check through the sympathetic and parasympathetic nerves. Whoever picked D should change their mind. Okay, with one person. Okay. Now let's talk about the adaptation to it. So this is different from all those things that have happened so far. Okay, and now what this adaptation is basically, all right, we've stimulated our effector organs, our heart, our blood vessels. Okay. Now what happens as a result of that? What's happening physiologically? Okay, we have sympathetic stimulation to the heart, arterioles, venules, right? And ultimately, the goal of this is that we're going to raise mean arterial pressure. Right? That's where we're headed. Okay. So, and we've already alluded to some of this, but what does sympathetic stimulation do to the heart? Right, we said it alters two things, right? What are they? Heart rate and contractility. Okay, and contractility translates to what happening stroke volume. Okay, so heart rate goes up and stroke volume goes up. Okay, these are two factors that make up cardiac output, right? The cardiac output goes up. Right, we're pushing more blood into the arterial system per minute. Okay, so that raises mean arterial pressure. We'll follow that. Pretty straightforward. Yeah. Okay. All right. Next thing is that we'll jump down to the arterioles. What happens when we stimulate those arterioles with norepinephrine? Vasoconstriction. Vasoconstriction happens. Come on, button. Okay, we get arteriolar constriction. Smooth muscle contracts. All right. And how is this going to affect mean arterial pressure? What value does it change? Resistance, right? It adds to our total peripheral resistance. Okay. Remember this diagram where we had the mean arterial pressure, and you could either shove more blood into it to raise the pressure, right? Or you could restrict the outflow, the resistance. We're doing both of these things, right? We're adding more blood per minute, and we are constricting the outflow to the capillaries, right? We are restricting blood flow through the arterioles. Okay, so that elevates mean arterial pressure, right? And this is part of our adaptive response, right? We're returning to a state of normalcy. So we start with a drop in mean arterial pressure as our initial insult, and what we do is we return it back to normal. Okay, so this elevated MAP, we don't elevate beyond normal. We're elevating back to normal. We don't want to overshoot. Okay. What do we do to veins and venules with sympathetic stimulation? Venoconstriction. Okay. And how does this contribute to MAP? Very negligibly contributes to resistance. So it does. Remember we said that when they constrict, they don't get a lot smaller. What do they do instead? What property changes? Their stiffness or their compliance, right? So yes, a small part of this is that it elevates resistance, but the much stronger component is that these vessels become less floppy, more rigid, less stretchy, okay? So their compliance has gone down. They're less compliant, less stretchy. So what does that do? We talked about this before, but just to put it in this context, what happens when those vessels become less compliant? increases venous pressure, and therefore venous return. Okay. Increases venous pressure and venous return. And how does venous return affect anything? Stroke volume. Right. Okay, so we could draw an arrow like that. So it affects venous return, which is through this principle of preload, Frank Starling law. It's going to lead to more contractility and therefore more stroke volume. Okay, more stroke volume is more cardiac output. Okay, this seems like overkill, right? It's a lot of stuff happening. All of these things that happen are happening on a sliding scale, right? It can be a very slight correction, or it can be a huge correction, right? So mean arterial pressure is very, very important because this mean arterial pressure is what's driving flow through the body. Okay? We want to keep it high so that we can keep blood moving, right? And if we don't keep blood moving, we're not going to be dropping off oxygen to our cells. And we die. So this is incredibly important. Feel good about this? No? Okay, we'll put it this way. There's something here you don't understand. Clarification of it. Yeah?
So the end result that we're trying to get to is increasing mean arterial pressure.
That's the end result. There's something else that we should address here. Let's say we lose a liter of blood. Okay? We've dropped our mean arterial pressure, and now through all this activity, we've managed to raise our mean arterial pressure back to where we were in the arteries, right? So the mean arterial pressure is almost where it should be. Okay. We've got what's different though? What's changed in the body? Yeah, we still have a volume deficit. Okay, and that's for the kidneys, okay, and we'll talk about that at a later point. And that's the hormones that respond to this system as well, with renin, will cause some changes at the kidney to retain more water, will cause some changes at the brain to make you thirsty, working through another hormone. And yeah, it's complicated, right? So there's more good stuff to come in this class, but we'll take it slow. But for right now, we're going to focus on this. This is the big part of it. And we can live without a liter of extracellular fluid. We're going to be okay because we have ways of making our mean arterial pressure high enough that we can still get flow, carry that oxygen to our capillaries, okay, even with a volume deficit. But yeah, we do have ways of addressing that. We have ways. Okay, so let's take some examples. This is not intended to confuse anyone. This is intended to help you apply exactly the same thing we've been talking about. Okay, so this is not really a lot of new information. It's a way of putting it in context and giving you some practice in running through thinking cause and effect as we go through. So we're going to talk about a few cardiovascular disturbances. You've all heard of shock, right? Shock sometimes is presented on TV as in something really bad happened and that person is disturbed as a result of it. Okay, that's not shock. It's being disturbed by what you saw. Shock is a loss of blood pressure. Okay, it's a sudden and severe loss of blood pressure. So strictly speaking, it's hypotension. Could be accompanied by hypovolemia, but strictly speaking, it's hypotension. Okay. And we've talked about one of these examples already. So hemorrhage is a type of hypotension. And if you'll notice here, there's 3 types. And I bet every one of you could tell me what these mean. If it's cardiogenic, what does that mean?
Heart.
It's a problem with the heart. Okay? In other words, the low blood pressure has arisen due to something wrong with the heart. If it's hypovolemic hypotension, it's the result of low blood volume. Okay? If it's low resistance hypotension, what's the problem? low resistance. See, easy. Okay. We could brainstorm some ideas here, but if you're not looking at your slides, because the answers are all there. What are some things that could make you lose volume besides losing blood directly? Yeah. Sweating. You can sweat a lot. Seems like it would take a lot of sweating, but people could do that. Yeah. What else?
Like a diuretic.
A diuretic, sure. You'd lose lots of water through your urine.
Vomit.
Vomiting. What's the other diarrhea? Looking for the right word. A friend is not really a friend of vomiting. Diarrhea. All right. So here's a bunch. Counterpart? I don't know. Polyuria. That's good. That's lots of urine production, excessive urine production. Okay. And burns. Burns because the skin helps us retain water, and if we burn our skin, we lose some of the protections against evaporation. Okay. Over on the cardiogenic side, we have a myocardial infarction, which we'll spend a moment talking about. This is a heart attack. Okay. And then we have vasovagal syncope. What is syncope? Anybody know? Fainting. Okay, so syncope means fainting. And vasovagal is referring to the fact that it's there's a blood vessel, that's the vaso problem. Okay. And vagal refers to your vagus nerve, which carries the sensory information up to your brain. Okay, so and it also carries information down to blood vessels in some places in the body. So we can have a low blood pressure that results from sort of an emotional disturbance in some people that side blood. For whatever reason, their blood vessels can dilate and they lose blood pressure. It's weird. Okay. Vasodilators, right? So this could be the result of an immune response, like a normal immune response, but it can also be due to allergic reaction, very strong immune response. So I am not going to ask you to remember all these things, but I want to sort of get you to start to think about some of the wide variety of causes that could contribute to this. Okay, so it's not just hemorrhage. Okay, so here's an example. We'll walk through this one together. Okay, we'll do this together, but use your brains. All right, so let's say, all right, Rudy's ventricles have been weakened by a heart attack. Okay? Heart attack result from the blockage of a coronary artery. The cells die that are fed by that artery, and so now we have a weakened heart. So we have low ventricular contractility as a result of not enough heart cells that are functioning. Okay? The idea is what would give us our initial insult. How we can define the initial insult. What goes wrong as a result of this? Okay, so stroke volume is going to be low. Right? So the low contractility means that the heart is not able to pump blood, right? In very simple terms. Okay? Low stroke volume is going to lead to what? Low cardiac output. Right, which leads to low NAQ. Okay. So this is not unlike hemorrhage that we talked about, but this is how would you classify this type of hypotension? Cardiogenic. Okay, so that's the insult. This is what happens. None of the response to it, none of the regulation that I do to fix it, but this is the problem. How do we detect this? Simple enough. There are receptors. Are they going to be more active or less active?
More.
Blood pressure is high, baroreceptors are more active when it's low, less active. So baroreceptors are less active. Okay. Reflexively, what's going to happen? How do we do something about this? Sensory information, right? nerves. Cranial nerves. I hate writing. My X. X. Okay. Sensory nerves. We're going to take the information where? Cardiac centers. Right. And from the cardiac centers, how do we finish up this reflex? Which way is it going to go? Sympathetic or parasympathetic? Sympathetic. Okay. So, neurons are going to go down the spinal cord, out the spinal nerves, and from the spinal nerves, we're going to go over the heart, and we're going to have sympathetic innervation to the, come back to that, where we contact the heart. Yeah.
Even if it was parasympathetic, it would still be cranial nerves.
Yep. Yeah, this doesn't change. So the cranial nerves 9 and 10 here, they're conveying sensory information to the brain. Okay. If it's parasympathetic, the motor output will be along the vagus, right? And if it's sympathetic, it's the spinal nerves. Okay. All right. So what sympathetic targets are what? Nerval cells and contractile cells. Okay, simple enough. So what's our adaptation? What ultimately happens here? Come on, back row. Make you proud. I try to get some out there. No. Do it for yourself. No, it's good. It's fifth grade, they're 10 and 12. Middle school, fifth grade. Yeah. You have a question, or you? You got a dog? Yeah, great too. Go ahead.
One of the arterials.
Thank you very much. We have arterioles. What are they doing? Are they dilating? Thank you. Constricting. Sorry, it's just killing time. What else happens? There's no vein. What do they do?
Constrict.
Okay. All right. What else? Oh, actually, arterial constriction. What's the adaptation? What happens when we constrict our arterioles? Okay. Increase TPR, total peripheral resistance. Veins constrict, and what do? Increase venous return, and therefore stroke volume. Okay. What about the heart? Do we innervate the heart? Yes, we do. And that is going to do what? When we innervate the nodal cells, we increase heart rate. Contractile cells, stroke volume. Okay? And that's good. All of these things here, stroke volume, heart rate, stroke volume, that's going to result in an elevated cardiac output. Okay? Cardiac output and TPR, these are all going to work together to elevate MAP, right? So that's the Big Daddy conclusion, a very important, super duper important response. Elevated MAP. Yeah.
So is the goal always to increase the
Yeah, that's the goal. MAP is important in the body because if you remember back to our discussion about flow equals delta P over R, MAP is essentially our delta P. Right? Our mean arterial pressure, we've got close to 0 on the other side. Right? So that high pressure is what's driving blood throughout the body. Okay? So if we have a low pressure, we're moving less blood. We have low flow. We need high flow because we need to deliver oxygen. That's sort of the key to why we care about the flow of blood through the body, is that it's delivering oxygen. That's probably the most important thing that it does, okay? Or at least the most immediately important thing. Okay. So let's talk about another one. We're going to talk about congestive heart failure. Anybody heard of that? That's a good one. Not a good one to have, but it's a good one to know about. Okay, so as I said last time, a heart attack can result from coronary artery that has been occluded. Coronary artery disease, if you don't die of cancer, you're probably going to die of this, statistically speaking. If you take a look at all of your arteries, you already have some degree of coronary artery genes. And you can look at children when they do. This is sort of a problem that all humans have. Okay? And the issue is, does it lead to a heart attack or does it not? Okay? What happens is we get a buildup of plaque, okay, which is the result of cholesterol, result of a pro-inflammatory environment. And this plaque builds up, there's a cellular response. This plaque is it's not made of cholesterol, it's a result of cholesterol, and it's big globs of cells and some cholesterol and other things there. And in some cases, we don't understand why entirely, that can break off and occlude the artery. Other cases, it grows to the point where blood can't get through. Yeah, something we all have going on in us right now. Okay. Sad, isn't it? Okay, very sad. What happens when an event like this takes place? Either the occlusion is complete or a portion of this plaque breaks off and occludes the artery, is that we get ischemia. Okay? Ischemia is the lack of oxygenation to a tissue. A tissue is said to be ischemic when it has no oxygen supply, and as a result, the cells die. Okay. Not all heart attacks kill people, right? Lots of people live through heart attacks, and but what happens, or can happen, is that a little portion of the heart has less contractility. Okay. And what congestive heart failure is a result of when this happens asymmetrically. Right? So the example we'll run through is if this happens here, this is on the left side of the heart. Okay. So we've got a little initial event here, which is we've got the death of some cells in our left ventricle. Right. Okay. So we're going to survive this heart attack. Good for us. Next step, our initial event is to look at the insult. Okay. So our insult is that we have less contractility, lower stroke volume, and therefore lower cardiac output, lower MAP. Okay. So far this is kind of like our congestive, like our cardiogenic hypotension, right? So what's going to happen to your cardiac output? It's going to be lower. Okay. So I'm just going to throw up a number here. I'm making this up out of thin air. Let's say it's 4.5 liters per minute as a result of this insult. Okay, so here's where we get to the problem. What do you suppose the other side of the heart is doing? What do you suppose its cardiac output is?
5.
5. Okay, so let's assume 5 is normal for this person. Okay, so we've got 5. Okay. Why this is called congestive heart failure is because there's a congestion in a backup of the tract. Okay. So we can ask ourselves what's going to happen to our hydrostatic pressures. Okay. So what do you think is going to happen to our hydrostatic pressures? Let's say down here in our systemic circuit. Okay? Capillaries that are going to feed our body's tissues. What's going to happen to the pressure down here in the capillaries? It's going to be lower or higher than usual? Lower. A bunch of you are pointing. Okay. So we're going to have a low pressure down here. Okay. This is a low capillary blood pressure. So normally it's 35 we talked about, remember that? And why is this hydrostatic pressure important? Yeah, this is the major force behind the filtration pressure and the pressure opposing reabsorption. Okay. What about up in the lungs? What about the lungs?
Higher.
Well, let me walk you through this here. Blood is coming out of the left side at 4.5 liters per minute. And it's attempting to go into the left side at 5 liters per minute, right? So what's going to happen is that we're going to get this buildup of pressure. Okay, it's going to be throughout the pulmonary circuit. What happens here when we elevate pressure of our hydrostatic pressure here? What process does it favor? Filtration. Okay. So in the systemic circuit, we might actually have a little less filtration than usual. Okay. Maybe a net reabsorption as much as possible. But what's really the problem here is that we're going to have an excess of filtration in the pulmonary circuit. So where are these capillaries? Pulmonary circuit capillaries. They're in the lungs. Okay. So when we have this elevated pressure, we can have edema, right? Remember we learned about edema? So with congestive heart failure, we've got this situation where we've elevated our capillary hydrostatic pressure in the pulmonary side. Okay. We've elevated on the pulmonary side. And again, just if you're not clear, it's because we have 4.5 liters coming out, and we've got 5 liters attempting to come in. All right. So what happens is we get a backup of our pressure. Okay. The heart can't handle the 5 liters per minute. All it's doing is 4.5. Okay. So we get this fluid accumulation. Okay. And it's called pulmonary edema. And the interstitial fluid here is the cells that make up the alveoli, or between the cells that make up the alveoli. Remember alveoli? We'll cover them more, no worries. The little air sacs, right? And these little air sacs have lots of capillaries, which helps gas exchange. And we get this accumulation of fluid, okay? And that fluid can leak into the alveoli themselves, the air sacs. Okay. All right, somebody take a stab at why that's a bad idea. You need all that surface area inside of your alveoli for gas exchange. Okay, you start filling up with fluid, you have less ability to exchange gas. Okay. All right, so I've got one more here for you to do. This is on your own. Actually, 2 more for you to do on your own. Not today. Well, you can do it today if you like, but we're not going to do it now. But these will serve as practice for you to try to work your way through these issues. I've got a brief announcement for you before we end today. Okay, so my buddy, my pal, Seth here is going to help explain something to you. Okay?
Okay, who likes 253 way better than 252L? Cool, that's what I figured. So, as a component of trying to teach anatomy better here, Dr. Johnson and the current lead anatomy, TA Halepox, and I have put together a study that we want to do. That's right over here from Wilson. Okay, so the purpose of this study is going to be using ultrasound to help you guys understand anatomy and spatial relationships. What we're going to be doing is we're going to be doing 2 Saturday sessions that are going to be relatively small, so unfortunately not everybody will be able to sign up for them. But what they will be is next Saturday the 15th, and then Saturday the 29th. There will be 1 session each day. It'll be for 3 hours. We'll be asking you guys to come in. You'll take a pre-assessment where you'll kind of do a little scavenger hunt with the ultrasound probes with some medical students who will be there to help proctor. And then what you'll do is you'll get just kind of a very quick lesson, just reiterating some anatomical concepts that you picked up in 252L and in 253L. And then what we're gonna do from there is we will have you take the same assessment again at the end. So, a couple of important points. This is not mandatory. It will not affect your grade if you do not do it. But it should be relatively interesting. It should be a lot of fun for you guys. I will have 30 slots available for people to participate. If you want to participate and you cannot get one of those 30 slots, your other option is to volunteer to be someone who is scanned. So anyone who volunteers to be scanned, you will still also get a chance to practice with the ultrasound probe and work with it and learn. But you're also going to be there mainly to be a model. Now we'll have enough people each day that you should get half and half of your time to be able to be scanned or be scanned. There will be a sign up that will go live. You guys will get an announcement from your Sakai site at 2, so in like 15, 20 minutes. There will be a sign up genius. If you have any questions about the study, let us know. The one thing I'll say before you go anywhere, the one thing I forgot to say, if you are volunteering to be scanned, just as a heads up, we'll be doing abdominal scans. And so you'll need to probably be able to take your shirt off. Most females prefer sports bras or something like that, just as a